and good morning to all. Welcome, and thank you for joining us for our annual event, held virtually now for the second time. First, I'd like to take a moment to thank some key people. I'd like to recognize the hard work of Gwenda Summers, Angie Wilcox, Amy Cowper, Lisa Lewis, Chris Ward, Alicia Eccles, Rachel McCoy, Joel Hefner, and Joyce Tenard in overseeing the many details required to put this event together and to create our annual report. I'd like to thank our CMHA-CEI Board of Directors for their ongoing leadership, dedication, and engagement. A great big thank you to our sponsors and event partners listed on the PowerPoint slides. Thank you, Platinum sponsor, Titus Talent Strategies. Thank you to our gold sponsors, Michigan Group Benefits, LCC, Beacon Specialized Living Services, Incorporated, and Lansing branch of NAACP. Thank you to our silver sponsors, HC Ryan and Company, Open Arms Link Royal Care Link, Cypress Home Care Incorporated, NAMI Lansing. Thank you to our bronze sponsors, Cedar Creek Hospital, Inspired Action Motivates, City Pulse, Mahoney and Associates Incorporated, Forest View Hospital, and Child and Family Charities. And special thanks to our event partners, Community Mental Health Association of Michigan, WILX, City Pulse, Chase Creative, Deb Brown Clearview Captioning, and Youth Haven. We appreciate your support today and our ongoing partnership throughout the year. And lastly, thank you to the resilient individuals and families we served in 2021 for their inspiration, and to our dedicated Community Mental Health Authority of Clinton, Eaton, and Ingham Counties superhero staff members whose efforts allowed us to continue service delivery throughout the challenges we faced in 2021. I'm also very pleased this morning to present to you our 2021 annual report. You can follow along with the PowerPoint as I take just a few more minutes this morning to share some key highlights. So we start on page 3 with the definition of resilience from the American Psychological Association as the process of adapting well in the face of adversity, trauma, tragedy, threats, or even significant sources of stress. This definition truly embodies life and work in 2021. And pages 3 through 5 of our annual report includes many highlights from across our entire organization that illustrate and celebrate resilience as we re-engaged, adapted, and increased in-person services while also integrating telehealth options. On page 6, you'll learn more about our Consumer Advisory Council. Our CAC members represent consumers and families from across our service array, providing input to help improve our service delivery. In the member spotlight, you'll meet CAC member Lori along with her engaging son, Zach. Pages 7 through 8 share stories of resilience as we rose to new opportunities, starting new programs and services to meet the emerging needs of the community. Covered is the Families Forward new Integrated Community Youth Outreach Unit, outpatient substance use disorder service expansion in integrated treatment and recovery services, and the new location and expansion of our CSDD clinical services housing autism and other therapeutic supports. Pages 9 through 10 highlights honest and inspiring stories of recovery from substance use disorder. Page 11 through 12 highlights the stories of two individuals as they found success and meaningful employment through their partnership with the CSDD Vocational Services team. Page 13 highlights the partnership between CMHA-CEI Adult Crisis Services and Meridian Township Police to pilot a tablet model of crisis intervention in the field. Officers in the community can immediately connect a person having a mental health crisis with our crisis services unit to triage and develop next steps in best meeting the needs of the individual. It has been very successful in connecting individuals to care while reducing the need for the police to immediately transport the individual away from their home. Page 14 highlights whole person care provided to a child and his family that were experiencing multiple psychiatric and physical conditions. Under Certified Community Behavioral Health Clinic services provided by Families Forward, multiple therapies along with the support of the nurse care manager made all the difference in coordinating this complex care. Page 15 through 17 is where you'll learn more about the Certified Community Behavioral Health Clinic model that CMHA-CEI has embraced. Read about the significant improvements seen in individuals receiving care and what some of our community partners are saying as a result of our work. Page 18 shares more about the important work of our Diversity Advisory Council, working to immerse diversity, equity, and inclusion into our organizational structures with the assistance of several employee-led work groups. It is a journey we are committed to continuing. On page 19, our ongoing prevention and outreach efforts are highlighted, along with many of the community partners involved in these efforts. On page 20, please see information and pictures from the 2021 Walk a Mile statewide rally held at the Capitol in support of individuals and families served in the public behavioral health system. Page 21 highlights the enormous work of our Human Resources Department as they stepped up to help us address behavioral health workforce shortages in multiple creative ways. Most recently, they've joined with WILX to launch a recruitment and retention campaign called Work at CMHA-CEI and Make a Difference. It features our own staff, and we'll be sharing these with you today. And finally, page 22 contains our revenue and expense information from 2021. When you leave today, I hope you'll take a minute to review the full digital version of the annual report, and that maybe you'll also pass it on to someone else. I thank you so much for your kind attention and for your ongoing partnership as together we celebrate resilience and look toward the future.
Sometimes kids have behavioral health challenges that make it very difficult for those around them to feel like they can manage them or support them.
We get to use our out-of-the-box and creative minds to try to remove obstacles and get through doors.
You know, we're always told, look for the helpers when things get rough. Like, here we are. We're surrounded by the helpers.
The first time you meet a family to the last time, your last meeting is totally different.
We're there to help the family to feel better and have a better way of dealing with life's unfortunate circumstances.
Families Forward is the portion of community mental health that serves youth with a serious emotional disturbance or SED and their families. We primarily serve birth through 18, although sometimes we see kids up to age 21. We serve around 2,500 people per year, that's youth and their families. And we have about 20 different types of services or programs that we utilize with families in order to fully support them in a continuum of care.
We really come in with a strengths-based perspective, and that means we look at what the families are already doing really well. And so when you have kids with trauma and they have a lot of behaviors, sometimes it's really hard for parents to know what they're already doing really well.
I'm kind of a skeptic sometimes, and you think, okay, all these services, and you hear about them, and here I am, a grandpa at 58 years old. You're going to tell me how to parent? You may have been there, but I can guarantee you haven't done it when you have a traumatized emotional child. And you don't know how to deal with that when all of a sudden it's there in your lap. I think if it wasn't for the services with Family Forward and stuff that we're utilizing right now, I think we would be trying to mud through the waters of it and try to figure it out on our own. Be open, be truthful. If there's something you don't like, tell them, talk to them about it. If there's something you really like, ask if it can be extended. They'll do everything in their power to help you move you and the child forward.
What works for one family is not going to work for another family. We have to be individualized and creative and design something that will support that particular family and youth.
Families Forward has always had what we call our strength-based assumptions.
What it means is that we operate from a framework, a set of specific core beliefs. Those beliefs are our guiding principles about how to maximize lasting change and maximize our effectiveness.
When it comes to evidence-based practices, not only just TEFCBT, motivational interviewing, PMTO, DBT, so it's really awesome to be able to have those various tools, if you will. We've had clients that benefit from multiple evidence-based practices, so it's really great to be able to offer that.
I told the adoption agency and community mental health when we first started that, Grandpa adopted them to be Grandpa or, for a safe home. I wasn't meant to be a punching bag. Mobile crisis unit, we had to have them out last year. They help you in crisis, and then having a home-based therapist, that's been wonderful. I think that's one of the keys to success.
Mobile crisis allows the family to stay in the home.
Usually we just expect to be able to go on a call as soon as we get to work. Somebody is already called.
It's nice for us to be able to see the whole family unit and what their needs are, how they feed off each other.
We really do believe that the youth and the families, their best place to receive the best treatment, that's the best long-term, is in the community.
Home-based services are just that. They're services that occur in the family's home and/or community settings. There's such a distinct value to having treating clinicians go to where the families live and go to work and school. The home-based clinician gets the opportunity to experience the real up-close and personal picture of family relationships and dynamics.
We got introduced to Families Forward when the children were in foster care, and they recommended that both kids, due to their trauma background, that they get some help, not just for them, but also for us.
I'm just impressed as to the therapists in terms of them, being engaged and having an investment in our boys.
Our therapist actually came to our home and helped us as parents, giving us ideas on things that we can try. She would even go over to the school. So we didn't understand a lot, and we would just get so frustrated and be like, what do I do with this? And I think that's where therapy really helped us a lot.
We have so much flexibility and we have so much supports, not just therapy, to offer our families.
Respite is important because it provides a break for those families. In some cases, they might be foster parents who are, kind of struggling in the moment, and helps preserve that placement. It gives them a chance to reset.
The ability to have a lot of different services helps us fill the continuum of care, and it helps sort of tailor interventions for the families. Care coordination is a huge value of Families Forward. Oftentimes families have many people involved in their lives and many different types of difficulties going on. Our nurse care managers are able to work with families who have both medical needs and behavioral health needs.
We get referrals for clients with chronic health conditions, with diabetes, with obesity, with asthma, with seizures, with migraines, you name it, where that is really impacting their behavioral health. And both are struggling. If your behavioral health is low, it's going to really impact your ability to manage your chronic condition and vice versa. And we've seen clients do amazing things with their wellness coaching goals.
My daughter was experiencing some gastro problems, so it was landing her in the hospital often, and it was causing her extreme anxiety. Being able to process and learning some extra techniques to get her through her sickness really was the most beneficial thing.
So in our community living supports, or CLS, we have providers who take kids into the community and they learn how to ride the bus, or how you behave at the restaurant or the bowling alley.
We might be referred for community living supports when there's a particular skill that the youth needs to work on in order to improve and enhance their kind of clinical treatment. So that might be working on peer relationship skills, that might be focusing on transitions, it could be enhancing their social skills in the community, that kind of thing. Our services are referred from any of the therapy services within Families Forward here. So they will have either a therapist or a wraparound facilitator.
The way I think about it is that we are literally wrapping around them in a big old hug with the team, and we're just walking with them throughout their journey, making sure they feel like they have a voice and that we can support them.
The thing that makes the difference in Families Forward is the deep respect for families, the belief that families have the solutions, the belief that families are the key to their child's success, and that change just happens in small incremental steps sometimes, and we need to keep kind of growing that.
Our commitment really is to walking alongside to help figure out and test out what might be helpful.
We're going to go where you want to go. We want to make sure that you have a voice.
Without their help, with the stuff that we were dealing with, I don't know if we would have been successful.
24/7, they let you know you have support. It felt good to have somebody there to talk to and to process.
We hope someday to not need the services. We go on with a normal life. And part of that will be due to the fact of the services that we've received to help us get through this.
Dr. Jones-Harden is an Alison Richman Professor for Child and Family at the University of Maryland School of Social Work. She directs the Prevention and Early Adversity Research Laboratory, where she and her team examine the developmental and mental health needs of young children who have experienced early adversity, toxic stress, and particularly those who are in foster care and have experienced trauma. Another focus area is preventing maladaptive outcomes in those populations through early intervention childhood programs. She has conducted numerous evaluations of such programs, including early child care and education, home visiting services, parenting interventions, and infant mental health services. Dr. Jones-Harden is a scientist practitioner who uses research to improve the quality and effectiveness of child and family services and to inform child and family policy, especially in the area of child welfare. She is currently the vice president of the board at 0 to 3 and serves on various federal, state, and local advisory boards. She received her PhD in developmental and clinical psychology from Yale and a master's degree in social work from New York University. Today, she will continue to promote our message of hope and resiliency. She'll discuss what really helps with youth and families, and she'll talk about leveraging and building community resources to support and promote integrated care in healthy communities. Thank you, Dr. Jones-Harden, for being here with us today, and we look forward to your inspiring presentation.
So I'm excited to be here because you all are focusing on a topic that is very close to my heart and to my head, and that is a focus on early childhood mental health. I have been doing this work for a very long time, but just to let you know, and this is something that I often don't say in my bio, and that is that I started my career as a child welfare social worker and really started to think about some of the things that were coming up in your video when I was going to help families work with children who were in foster care or relatives who had taken in children, just the kinds of things that you highlighted in that video. I thought, I'm a pretty good clinician, but I don't know anything about little kids. And certainly I was finding that in terms of prevention, I wanted to start as young as possible. So I take my hat off to all of you here who are focusing on this very important topic. So I'm going to move forward and hopefully everybody can see my screen. And what I'm going to do is talk about something that I call triple jeopardy. And that is that young children who are living in impoverished households and who are from minoritized backgrounds have a particular vulnerability. Basically, age, SES, and race compound to make these children very vulnerable to a variety of risks and therefore much in need of the kind of mental health services that your organization here provides. So just so I can convince you of this, this is one slide. I'm not going to show you a lot of data slides, but I thought I would show you a couple just to make my point that although the rates of child poverty thankfully are going down in this country, although we probably are going to see a blip because of the COVID pandemic, what we do see is the increasing gaps between children who are growing up in poverty and children who are not. So particularly when you sort of go down the line and look at infants and toddlers, you do see a disparity in those children between middle class and low income children. And the rates for infants and toddlers, for example, is close to 20%. And we do know that if you think about child poverty, it's most likely to affect very, very young children. So just like very, very young children are vulnerable to, the vestiges of child welfare, right? They are more likely to be abused, more likely to go in foster care, those kinds of things. We also know that the poverty rates are highest among those children. That said, it's also critical to recognize that when you look at children who are in minoritized backgrounds, for example, look at that middle part of the graph about African American children, you see that about 1/3 of infants and toddlers are growing up in impoverished circumstances. So just to sort of, again, drive this point home about what young children experience, we know that if you think about poverty rates according to the federal guidelines, which we know are antiquated and we need to do better than that, they were based on USDA standards from many, many years ago. But if we take 200% of the poverty line, right? So people who have two children, two parents, and who are living as a family of four, right, making about $40,000, $50,000. That's about 200% of the poverty line. Nearly half of young children are living in those families. When you think about right at the poverty threshold, that antiquated threshold, $24,000 or so, that we know from the federal government, about 1/4 of young children live in those households. But think about the kids who live in deep chronic poverty, which we know has the most devastating effects on children. We are seeing an increase in those children who are living in deep poverty. So again, what we know about infants and toddlers is that they're growing up in very, very vulnerable circumstances. On top of that, we know that the outcomes for those children, if you experience poverty as a young child, the outcomes are much more pernicious. In other words, they are more debilitating, but also they last for a longer time, right? For example, think about what we know about mental health outcomes. That's the thing that you all are talking about here. We know that children who are growing up in poverty are more likely to have behavior problems, for example, in the adolescent period, which came out greatly in your video. But we also know that children who are growing up in poverty are experiencing disparities in their service receipt. So when you think about, for example, mental health services, I'm focusing on that because that's what you all are here to think about. We know that young children in poverty are much less likely to receive mental health support services than middle class children. Similarly, when we think about race, we see that African American and Latino children, as well as Native American children, not, Asian children are a little different. It depends on the country of origin, like Southeast Asian children look much more like other minoritized groups. Children from China and Japan look a little different, probably because of the time that these groups have been in the United States. But if you think about mental health disparities, we do know that these children are much less likely to receive appropriate mental health services. Okay, I'm going to bring up ACEs, and I'm not going to talk about it a lot because I'm sure many of you have had many trainings on ACEs, but I do think it's critical to bring this up. Now, those of us who've been in the field as long as I have, we talked about ACEs a long time ago. I've been in the field like 40 years. We didn't call it ACEs. We didn't have that beautiful study out of Kaiser Permanente in California that linked these adverse childhood experiences to physical health outcomes that cost this country a lot of money, like stroke and hypertension. We didn't have those data, but we certainly knew that these early experiences were horrendous for kids. And I already mentioned to you that children who are growing up in low income and impoverished households tend to be more vulnerable anyway. Similarly, they're more vulnerable to receipt to exposure to these ACEs. So as you will probably remember, those of you who've had these kinds of presentations, you know that the ACEs questionnaire asks about some very important things for people like us who are concerned about children's mental health. For example, they asked, did you experience abuse in your childhood? They asked, did you experience neglect in your household when you were a child? They asked, did you experience these household dysfunctions? All right, so we know children did that. But what, again, was so beautiful about this ACEs study was that they linked these early experiences to negative mental health outcomes, but more importantly, for the insurance field, Kaiser Permanente, who funded this original study, it was linked to all these physiologic problems that have high price tags in this country, like severe obesity, diabetes, heart disease, cancer, stroke, COPD, all these kinds of things were related to the adult's experience of these things in early childhood. So what does that suggest to us as mental health providers? And that is that if we could address some of these ACEs during early childhood, then perhaps we could prevent some of the later mental health problems and indeed prevent some of the later physical health problems that lead to early death. All right. I love Jack Shonkoff. I'm a Jack Shonkoff groupie. As I said, if you all haven't looked at his website, Center for the Developing Child, I highly encourage you to do that. He's at Harvard. He's got wonderful resources that you can just download and use. But one of the things that he talks about is this framework for understanding why we see that ACEs is predictive of all these kind of things. So ACEs just asked about, did you experience these things in early childhood? That's what the questionnaire focused on. But Jack Shonkoff, his framework helps us to think about the mechanisms by which this could happen. So he calls these ACEs, he calls them stressors. He actually calls them toxic stressors, right? So in other words, these are stressors that have so much of an impact on your body that they lead to this prolonged activation of the body's stress response system. And one of our stress hormones, obviously, is cortisol. And if you have cortisol running through your body, it starts to affect all of your organ systems, including that very important organ that is called the brain, right? So Jack Shonkoff argues that things like chronic poverty, which we've talked about, but also racism and trauma and child abuse and neglect, these are toxic stressors. Now, I want to say that one of the things that Jack Shonkoff argues in his definition is that if you experience these stressors in the absence of a protective relationship. That's the important part of what he says. In the absence of a protective relationship. Why is that so important? Because it suggests that there is something we can do about it. Maybe we can't, even though we should morally, not have American children experience chronic poverty. Even though we can't necessarily get rid of racism, although we should, even though we can't necessarily prevent trauma, although there are ways we can think about that, and I'll talk about that later. What he argues is if you give children a protective relationship, like that wonderful grandpa in that video, that you can buffer children against these toxic stressors, okay? Now, this is important. That biological embedding, right, affects many different systems, including the brain, but also your immune system, your cardiac system, the telomeres are these little things that are caps on the neurons that, can tell you about cellular aging. They get shorter and shorter and shorter as we all age. People who've experienced toxic stress have shorter telomeres before they should, right? So their telomeres are they go on a fast route to getting shortened, so that you see premature cellular aging in people who've experienced toxic stress. And then, of course, what you get are these behavioral outcomes that mental health providers have to go in adolescence and try to address. So again, if you think about this from a preventive early childhood mental health perspective, we are trying to buffer these children with these protective relationships. Not that we can provide, we can't give young children what they need. We can help the caregivers of young children give them what they need. All right, so this is another depiction of this same idea from Jack Shonkoff that I really like. And if you look at the hot pink area, what will you see is those are the kids who've experienced these high impact, chronic kinds of stressors. But look on the left-hand side, in the context of low support and responsivity. Any of you who've heard Jack Shonkoff speak will know he talks about this serve and return, that a child says to a parent, I need you, please come, I'm worried, I feel unsafe, be responsive to who I am. And that's the kind of parenting that we want all these children to receive. So as mental health providers, we have to provide them support. I like to say fill their gas tanks, even though gas is so high now, right? But mental health services cost a lot as well. But fill their gas tanks so they can fill the gas tanks of these children. All right, just a couple little slides to show you how it affects the brain. If you look at the top slide, you will see a very rich set of neurons. You see lots of connections and branching off and everything. That's a kid who's growing up in a typical environment. And if you look at the bottom slide there, you'll see nubs, right? You'll see fewer neurons and certainly much fewer connections, which has implications. Think about for children's academic learning. If you are so stressed that the brain starts to be affected in this way, then it's going to be pretty darn hard for you to do the kinds of areas of functioning that every child should be able to master. All right, just another quick one about the brain. This is a PET scan, which is really looking at the brain's metabolism. How much energy does it expend to solve a problem, to engage with another? And what you'll see on your left is a brain that is with a child who has had a few risks, right? Not a whole lot. And you'll see the PET scan is showing a lot of red and a lot of yellow, which is suggesting that the brain is really working. The glucose is working to try to get the brain to have the energy to solve whatever problem is in front of them. Whereas on the right, the neglected child, you see far less brain activity, which suggests that the brain is kind of shutting down. And what you see for kids who've experienced that kind of abuse, neglect, chronic trauma is sometimes the brain just says, I can't tolerate this. I'm just going to go inside myself, protect this human being, focus on survival, and not focus on these higher level problems that are required in school and with my peers, etc. All right, so I want to talk about resilience a little bit because I've sort of painted this negative picture. But what I want you to understand is that's what we are working toward in terms of mental health, right? Look at the definition: positive adaptation or recovery in the context of adversity, right? So we get it that the children we're going to see are going to be the most vulnerable children. They are going to be the children who've experienced the most adversity in their environmental context. However, we do know from the resilience literature that it is not, one of these things that has to stay static. Resilience is based on your transaction with the environment. So if you have an environment that gives you a certain number of supports, you can move toward positive adaptation. And in fact, when we look at these children, we can see that there are certain children who do have decent outcomes in spite of these adversities. So we learn from these children's experiences about what we need to do for other children. Now, I want to hasten to say that what we have also learned is just because a child is resilient in one domain does not mean that they're resilient in another. For example, there are a lot of studies about Asian American children. They've been called the model minority because these children do very well in school, despite even coming here with some kinds of risks as immigrant children. Well, one of the more recent findings among these children, lots of studies have looked at this, is that there is a price to pay for that high academic functioning. That what you often see is lots of internalizing problems like depression and anxiety, increased suicidality, those kinds of things that suggest to us, yes, children might be resilient in one domain, but it doesn't mean that they're going to be resilient across, particularly when you think about mental health outcomes. So again, very important for the work that you all are doing. Another slide that points to resilience. This is an ACEs slide that has to do with whether a person who has childhood ACEs, right, ends up with depression at some time in their lifetime. So you look at this. If you've not experienced any ACEs, there's a much smaller likelihood that you are going to have depression. So maybe 20% of the population are going to have depression if you not experience any ACEs. Alternatively, if you've experienced 5 or more, right, you have a much higher likelihood of experiencing depression. However, it is important to look at those green figures, right? So 40% of people with 5 or more ACEs do not experience depression. So the question is, what is going on with that 40%? Can we learn from those kids and families and adults and try and figure out whether we can mimic those environmental contexts for other children? All right, so what is resilience? These kinds of internal functioning that allows you to adapt to whatever environment you're living in. So understanding emotions, being connected to school, having good problem solving skills, having good social skills, being optimistic, having hope about your future. All these kinds of things are important to be resilient in the face of adversity. But how do you get there? Well, there's some things that happen inside yourself as a kid that if you have the good fortune of having them, you're much more likely to have better outcomes in the context of adversity. So if you have an easy temperament, you kind of go with the flow, you kind of are more positive in terms of your personality, you are able to cope with a lot of changes, right? And we can see who these children are during infancy, by the way, right? Kids who have a higher IQ, they tend to do better, not just because they are good problem solvers and do well in school, but people like smart kids, right? So one can think about the environmental support that they get that a child who might have learning disabilities or might have low IQ across the board, they may not get that same kind of support from their environment. Children who are clear about who they are from a racial ethnic point of view have a very strong racial ethnic identity. Those kids tend to do better in the context of adversity. If you're just healthy, that helps. And interestingly enough, if you're a girl, you tend to have better outcomes in general, but also if you're a girl growing up in these kind of high-risk circumstances, you tend to have better outcomes than your male counterparts. Okay, we can't do a lot about those things. We can promote them. Certainly, we can certainly promote racial ethnic identity. The other things you kind of have to be born with. But look at all the things that we can do on the environmental side, right? As mental health people, we can work toward family stability, helping parents to be more responsive in that way that Jack Shonkoff talks about in terms of his serve and return. If they are families who have a connection to some kind of religious community, even though we may not, we can support those families' connections because that's where they're going to get some of the supports they need. We can support children's relationships with others. So hopefully we can get them a good, solid attachment relationship during infancy and toddlerhood. But we can also find them relationships with other adults in their community, that wonderful grandpa, but also coaches and things like that, right? We can try to work hard to get kids engaged in school. And we can work on finding as many neighborhood supports. Mental health is not just seeing a kid for an hour a week. It's not just going, even if you do home-based mental health services like what your agency does, you just don't want to have an hour. You want to make sure you give children a greater mental health intervention. I have a colleague, for example, who says a good school is one of the best mental health interventions you can get. So we want to make sure to connect these kids to a good school, good early childhood education experience, a good medical home, right? Because pediatricians are often the ones who know a lot about what's going on in these families early on, and certainly connect them to economic programs. So what am I raising here? That mental health for these kinds of children mental health services cannot just be 1 hour a week. They have to be much more comprehensive, and we have to work very hard to make sure that they have the case management they need. Now, here's my favorite slide, because what this slide suggests is that if you really want to put your money where your mouth is, if you really want to get children's outcomes to change, you want to do it at a time when the brain is most likely to respond to a different set of environmental experiences. And if you look at this graph, what it suggests is if you are under 4, that's when your brain is most plastic. So if we can get children to have these kinds of environments, supportive environments. Now, they might be living with birth parents. I'm not suggesting that we want to snatch them out necessarily to put them in a great foster home, even though, that's a great thing. But there are ways we can change birth parents as well to have them be more responsive. And we want to do this early on in the child's life when the brain is most plastic. Now, I will also say that if you look at one of the economic return on investment slides, you will see this exact same graph. That if you want to think about when you can get the most return on your investment from an economic point of view, so not having people depend on welfare, not having people be in special ed, not having people be in our incarceration system, all those public sectors that are not good for people, number one, but also that cost our society a lot of money, that if you want to try and alter that and reduce the amount of money that our country is putting out for people who end up in these systems, then you want to do your intervention early on. So I think we've got data from psychology and public health and now even economics that says it makes good business sense even to try and intervene early in a kid's life. Okay, so we know that early experiences shape brain development. You're not born with a bad brain, right? You were born with a brain that's ready, primed to get as much as it can from its environment. And so we want to keep that developmental trajectory going. And sometimes that means really trying to change the environment, the early experiences that children have. And as I said, doesn't always mean taking children out. It means doing the very good work that mental health clinicians do, which is really helping parents to improve their parenting, which is what really every parent I've ever worked with really wants. Okay, just another slide to convince you of the import of the first years of life. This is about what happens in the brain in terms of synaptic formation. And you all may have heard of that word synapse. It's the sort of connection between neurons in the brain, and it helps the brain to work more efficiently. And as it turns out, there is this overproduction of these connections in infancy, overproduction, because it's like the baby brain doesn't know what kind of environment I'm going to be in. So just to be on the safe side, I'm going to have as many different connections as I can so I can be ready for whatever I encounter in my environment. Well, of course, what we know is the brain can't handle all those connections. So as the child engages in his or her environment, some of those synaptic connections go away. They call it synaptic pruning or retraction, so that the brain becomes more efficiently able to deal with what kinds of things are in their current environment. A wonderful kind of developmental process that we've learned about because we now can look at the brain with EEG and PET scans and MRIs, so many non-invasive ways to understand what happens in the human brain. But what this slide tells you is that if you think about things that are critical for later development, like language, I go on a tirade about language. We know that oral language not only predicts kids' academic outcomes, but it predicts their behavioral outcomes as well, the fodder of mental health intervention, right? So one of the things we want to do is make sure that children have an opportunity to be stimulated linguistically. But look at where the peak, that's the red line, look at where the peak of that is, 7, 8, 9 months of life. So we really need to be working hard. And you see how it goes down so quickly, those pathways in the brain for language. We want to make sure that children have the opportunity to have those experiences. And that's part of what dyadic mental health therapy can allow. In fact, one of the interventions that we've worked on is developed by Mary Dozier. I'll tell you about it later on. She has found that her intervention improves children's language through this more responsive parenting. All right. Just another quick slide that talks about children in Romania and what we've learned about those children. There have been many people who've gone over to look at these children, and they've compared them to kids who've been adopted. This is a particular one that was done in Great Britain. And what this slide suggests is that there are sensitive periods of development. So the kids who went into the institutions in Romania but got out like before 6 months of age don't look any different from kids who grew up in families. But look at the kids who were in the institution 6 to 24 months. Much higher rate of cognitive problems. And then you look at the kids who didn't get to leave the institution until they were 24 to 42 months, even higher rate of cognitive problems. So again, this notion of really trying to change children's experiences as early as possible. All right, so how do we do that? That's what I want to shift to now. How indeed do we make this happen? Okay, so I'm talking about this as a beacon of hope, and I unashamedly took this from a book that my good colleague Joan Lombardi has written on beacons of hope. And she talks about early Head Start, for example, as a beacon of hope. But what she's suggesting is, despite what we know about all these early adverse circumstances, we also know a lot about what will make children's experiences different, okay? And so what my colleagues, many of them, and I'm certainly on this bandwagon, have talked about is an early childhood system of care, right? That allows young children to have the environments that they need to be able to stay on a positive developmental trajectory. We can't just do mental health. We can't just do good primary care. We have to think about the transition to parenthood. So we want to have good prenatal home visiting. We got to have good prenatal support services to make sure that pregnant women get the kind of OB services they need. I don't know if you all know about the data on African American women, for example, but very high rates of maternal mortality during pregnancy and delivery, and then, of course, very high rates of infant mortality, even higher than their low-income counterparts. So it's not just about income. In fact, when you look at the African American rates of maternal and infant mortality, they are higher across SES groups. So you see it even in middle income African American women. So what does that suggest? That very vulnerable period, we need to make sure we have the supports in. We need to have parenting interventions. We need to have mental health interventions. If the children are so vulnerable that they end up in child welfare, and I have a colleague who says the kids who end up in child welfare are the kids that every other human service system has failed, right? So we need to pull that system in. So it needs to be a coordinated system. And in fact, I have had colleagues like my colleague Ken Dodge in North Carolina who have created an intervention he calls Family Connects that's designed to sort of have this universal system that wraps around the needs of very young children to buffer them against some of these experiences. Okay, so where do we want them to go? We want them to be emotionally ready for the world, right? If we think about what early care and education is focusing on now, they're focusing on, you know, do kids know how to read? Can they recognize their letters? Do they have early numeracy knowledge, right? Well, our argument is it is just as important, I might even say more important, that children are emotionally ready for school. So part of what a mental health service system that pulls in all these other systems can do, pulling in early care and education, those kinds of things, can help children to be emotionally ready so that they can get through that very important experience of school. All right, so how do we think about this? Well, we can borrow from public health or the CDC and think about this multi-level approach to intervention. So on one hand, we're thinking about primary prevention, right? Primary prevention. And these are programs that really are designed to promote children's social emotional competence. So one could argue that this can go across for all young children. So a good mental health program really tries to make this universally available for all children. You can do public health approaches like my colleague Ken Dodge. You can do high quality early care and education, for example. You can have, if you want groups for these children, right? So this is where your goal is just to get children to have the skills that they need to get through the world, okay? Now, on the secondary side, however, and this is where agencies like yours sort of come in generally, it's when families present certain risk factors or children present certain risk factors that make us know that these kind of universal interventions are just not going to cut it, right? You need something that's a little more targeted. So you might want to do specialized parenting programs, and I'll tell you about one that we've done, ABC, in a minute. You might want to do family support programs in the community. You might want to have mental health interventions for parents, right? Like parents who suffer from depression or things like that, because we know that's a risk factor for some pretty bad child outcomes, right? And then on the tertiary side, which is where a lot of these therapies come into play, is when children have already been diagnosed, or, for example, have already come into the child welfare system or some other service sector where we know the very highest risk children come in. And that's where you want to provide your very, very targeted services that have to do with some of the home-based therapies that were discussed in that video. But what are we arguing here? That you got to have an approach that's multi-level, right? You got to have an approach that is sensitive to the needs of your family. So one size does not fit all. So I want to give you a few exemplars of that. But before I do, I just want to, you all heard that I'm the now president of 0 to 3's board. And 0 to 3 made a commitment to work in the early childhood mental health space from its inception, really. It was actually an organization that was started by early childhood mental health clinicians at a time when there were hardly any, right? So they wanted to create a field, and indeed they have, and 0 to 3 as an organization has really broadened its scope. But from its beginnings, it was, had a strategic priority to address these issues around early childhood mental health. And from their vantage point, it was about what kids' social emotional competence was, what their early skills were that allowed them to be well-functioning children, adolescents, and adults. And so they talked about things like being able to have close relationships with another, right? Being able to have experiences that supported who they were, being able to explore the environment. And they based a lot of this on attachment research. And if any of you remember this from your Psych 101 courses, you'll remember that you can't explore unless you have a secure base as a young child. So you can't go out like you see those kids running down the mall, the halls in the mall, and they turn around and they make sure their parent is there, right? So they're willing to go out and explore the world, but I'm going to check in and make sure my secure base is right there with me. So this kind of capacity for a good, solid social emotional foundation is what the early founders of 0 to 3 defined as infant and early childhood mental health. And they obviously, as my last bullet says, really thought about it in that same sort of tripartite way that I just told you comes from public health, where they looked at promotion, prevention, and treatment. And I called it primary, secondary, and tertiary, but it's the same idea. All right, so let's talk about promotion, right? So on the bottom, you want to make sure, this is the pyramid that comes from early care and education. And I just love it because I think it sort of speaks to what we need to be doing for children. On the bottom, you want to make sure they have positive relationships, and you want to make sure their environment is supportive. Then next, you want to have them learn the social emotional strategies that they need to be able to function in the world. And at the very top, these are the kids who would be in that third category, who needed a lot more. Those are the kids that would need those intensive individualized interventions. Okay, so what do we know about early care and education? And I'm thinking about it as an intervention, if you will, for kids' social emotional outcomes. Again, somebody else will worry about the academic outcomes, but let's just focus on the social emotional outcomes. That if children have a high quality, intensive, center-based early childhood education program, right? And I'm talking about children in poverty. It can buffer them against those vestiges of poverty. So that's number one thing. However, they need more if they are these kids with high levels of risk in their backgrounds. So you need to add on top of that, as you saw in that pyramid, more specialized interventions for these children. We have learned that if children experience that in the context of early childhood education programs, that you see a lot of improvement, even in terms of those problems like aggression, right? We also know, think about resilience and the importance of that relationship with the adult, that positive relationships with a teacher in this particular environment predicts academic outcomes through second grade, by the way, but also predicts positive social emotional outcomes. So again, think about what we've learned about resilience. We don't want early care and education teachers who are yelling and screaming at kids, which I've seen a lot. We want early care and education teachers who are going to provide that supportive, responsive relationship, because that relationship, again, is a buffer against those kind of environmental adversities. Okay? The best programs are 2-generational, right? Because think about what I've said. For little kids, you want to make sure that you're working on that caregiver, right? So working on the child and working on the parent. There's a promotion part where you're trying to promote typical development. That's their primary. You want to screen for things like child and parent trauma. We've gotten our early care and education programs to do that as a matter of course. You want to make sure those teachers are nurturing in the way that I just talked about. You want to do interventions in the classroom. And now there's a whole field of early childhood mental health consultants who are going into early care and education systems and supporting teachers with how to manage the classroom to help children who might present with some, social emotional needs, to integrate more in the classroom, to have teachers be better classroom managers, to have teachers know what to do with those children who are presenting with behavior problems. So a whole field of early childhood mental health consultation with some very nice results showing that we can go into these classrooms and help them, right? And again, this idea of a system of care, you've got the early care and education as a primary preventive intervention, if you will, but you add to it these secondary and tertiary interventions that allow for children who are presenting with higher levels of risk to get the kind of services they need.
Well, it's been a wonderful, enriching morning, and I thank you to Families Forward for hosting such a wonderful event today, and our appreciation to Dr. Brenda Jones-Harden for joining us today to inspire and encourage us all in making a difference in the lives of children, families, and supporting our community. So once again, we thank you all for joining us virtually today. We look forward to seeing you next year in person at the Lansing Center.